Assalamualaikum and hi everyone. Welcome back to PHC 503 Cardiovascular System and Pharmacotherapeutics. In this week's lecture, we will discuss on the pharmacotherapeutic management of cardiovascular diseases. In this week's lecture, we will focus on the hypertension treatment. At the end of the lecture, we hope that you guys are able to discuss the assessment of hypertension and use the findings to guide the treatment initiation. Besides that, you should be able to relate the drug's mechanism of action and its therapeutic indication and recognize the dose, frequency, side effect of the most common prescribed medication. Here is the list of the most common cardiovascular disorder. There are many classes of drugs that are used for the treatment of cardiovascular diseases. To be simplified and easily be recognized, most of the beta blocker will end with LOL, LOL. For dihydropyridine calcium channel blocker will end with PINE3, PINE. For alpha-1 blocker that commonly used in hypertension treatment as well as off-label benign prostate hyperplasia will end as Zosyn. If you see the word PRIL, P-R-I-L, it refers to ACE inhibitor. If the word sartan come out from the medication, it refers to the angiotensin receptor blocker. The word daron at the back refers to anti-arrhythmia drug, and the word statin at the back is used for lowering the cholesterol level. Zolamide and Semide are the diuretic drugs. Meanwhile, if you encounter parin and rudin at the back of the word, it refers to the anticoagulant drugs. Hopefully, this table is somehow useful for you guys to differentiate the drug and their indication. Here is the summary of the most common drugs that used in the cardiovascular disorder. As you can see here, the pink color refers to the most prescribed medicines for particular disease, and the blue color indicate the prophylaxis drugs that used to reduce the mortality and morbidity and for the better outcome. As example, besides nitrates that commonly used in the treatment of angina pectoris, beta blocker and calcium channel blocker will be prescribed by the physician as a prophylaxis drugs. In this week's lecture, we will focus on the pharmacotherapeutic management of hypertension. Here is the case study that will be used as our discussion throughout the lecture session. Hopefully, we will be able to apply the pharmacological cardiovascular knowledge that has been learned in this semester in the real practice by using this case as example. Mr. H.A. is a 50-year-old accountant who has admitted 2 days ago to hospital following a blackout while watching a football match with his son. His past medical history indicates that he is no medication and seems to be a reasonably fit for his age with no existing diagnosed medical conditions. On examination, he is slightly overweight at 81 kg. He is a smoker and blood pressure 165/90 mm per mercury with heart rate of 90 beats per minute. He was diagnosed as hypertension. Hypertension is a medical condition that can be defined by persistent elevation of arterial blood pressure with systolic blood pressure values greater or equal to 140 mm mercury or diastolic blood pressure values more than 90 mm mercury. Hypertension can be categorized as mild hypertension or stage 1 hypertension, moderate hypertension or stage 2 hypertension, severe hypertension or stage 3, and isolated systolic hypertension depend on their systolic and diastolic reading. The treatment goals of hypertension R to normalize the pressure, which our target goal value is less than 140/90, and want to avoid any hypotension and other adverse drug effects. Besides that, the treatment goals for the hypertension drugs are to reduce the morbidity and mortality, besides to prevent or retard an organ damage, especially stroke, retinopathy, heart failure, myocardial infarction, and kidney failure. For the target goal for hypertension patient is depend on the condition of the patients. For uncomplicated hypertension, usually the goal value is 140/90, and we will target 130 less than 130/80 for patient who has diabetes and other high-risk populations. Back to our case study, Mr. HA has no medication and no existing diagnosed medical conditions. Means that he is uncomplicated hypertension due to blood pressure more than 140 and diastolic blood pressure value more than 90 mm mercury. Mr. HA can be classified as stage 2 hypertension because the systolic blood pressure is within 160/279 mm per mercury, even though the diastolic blood pressure in the stage 1 value. So the desired target blood pressure for Mr. HA is less than 140/90 mm per mercury due to uncomplicated hypertension. In this slide, we will gonna talk about the algorithm for the management of hypertension. Aside blood pressure measurement, we need to assess the patient cardiovascular risk level for getting major cardiovascular event within the 10 years, as you can see in the middle table here. If the patient's repeated blood pressure measurement within the range of 130 to 159 mm mercury for systolic level or 80 to 90 mm mercury for diastolic, together with low to intermediate risk level, we will suggest him to having monotherapy hypertensive drugs. Besides that, for those patients who has more than medium risk or high and very high risk, together with the stage 1 and stage 2 hypertension, consider him or her to having the combination therapy for renal and cardiac protection. However, try to avoid prescribed combination therapy to the older patients. In Malaysia, many patients with hypertension have more than one other cardiovascular risk factor such as organ complication, organ damage, smoking, high cholesterol level. Each of these additional risk factors will cause increased incidence of cardiovascular risk substantially. Let's discuss the table in the middle here. If you can see here, the no RF means that no risk factor, which is no additional risk factor refer to the smoking, which total cholesterol level more than 6.5 millimole per liter, and has family history of premature vascular diseases. TOD refer to the target organ damage such as left ventricular hypertrophy, retinopathy, and proteinuria. And TOC refer to target organ complication such as heart failure and renal failure. For the patient has the clinical atherosclerosis such as carotid stenosis and peripheral vascular disease, they are considered to be has high to very high risk of getting major cardiovascular event within the 10 years. For post-myocardial infarction patient, ischemic heart disease, or previously has stroke attack, or diabetes patients or chronic kidney disease, we can consider them as a very high risk patient to getting major cardiovascular event within these 10 years. Let's back to our case study. we can identify that Mr. HA has one risk factor, which is smoker. As you can see there, the systolic blood pressure within the range of 160 to 179 mm/Hg, so that we can classify Mr. HA as high-risk patient or approximately 20 to 30% chances of getting major cardiovascular events within the 10 years. Aside the drug treatment, we need to advise him, counsel him to stop smoking to reduce the risk from high risk to medium risk of getting cardiovascular events. Since Mr. HA is a stage 2 hypertension as discussed previously, with high risk of getting major cardiovascular events within these 10 years, we should consider him as a combination therapy. But which drug that should be prescribed to him? The choice of drug should be individualized. Decision to initiate pharmacology treatment depends on the global cardiovascular risk as discussed previously. Patients with stage 1 or mild hypertension with low cardiovascular risk, we need to advise him to having a healthy living for a period of 3 to 6 months. Within these 3 to 6 months, patients should be seen at least twice to assess the efficacy of the non-pharmacological interventions. Stage 1 patients with medium or higher risk should be offered drug treatment upon diagnosis. Newly diagnosed uncomplicated hypertension and no compelling indications, we should suggest the physician to prescribe either ACE inhibitor, angiotensin receptor blockers, calcium channel blockers, or diuretics. All these 4 types of drugs have all been shown to reduce the cardiovascular morbidity and mortality. Beta blockers are not recommended as first-line monotherapy, except it should be considered in younger patients, in particular who having the intolerance or contraindication to ACE inhibitor and angiotensin receptor blocker, or women of childbearing potential, as well as patients with evidence of increased sympathetic drive. For those who receive the combination therapy for hypertension treatment, if the target blood pressure is not achievable, we need to increase the dose or change with a drug from another class. The table in this slide shows the condition of the patient and the proof of the effective combinations. For post-stroke or diabetic patients, the effective combination will be the ACE inhibitor and thiazide. For the hypertension patient who having the left ventricular hypertrophy, we should prescribe them with angiotensin receptor blocker together with thiazide diuretics. Meanwhile, for the coronary artery disease due to the hypertension, we can suggest either calcium channel blocker together with ACE inhibitor or beta blocker and thiazide. For very elderly patients, we can suggest ACE inhibitor and thiazide combination. For the medium risk hypertension, calcium channel blocker is the first line treatment. Combine either thiazide, ARB, ACE inhibitor or beta blocker. For those in the high risk hypertension, either we prescribe them with the calcium channel blocker with thiazide or calcium channel blocker with the ACE inhibitor aside of the angiotensin receptor blocker and thiazide. As discussed earlier, this patient, Mr. HA, is a high-risk hypertension. So, the effective combination therapy will be the calcium channel blocker plus thiazide or calcium channel blocker together with the ACE inhibitor or angiotensin receptor blocker together with thiazide diuretics. Diuretics, often called water pills, are drugs that cause the body to rid itself of excess fluids and sodium through urination. Excess fluid in the body can lead to high blood pressure. The diuretics inhibit the sodium-potassium synporter, which lead to inhibit the reabsorption of sodium ion, potassium ion, calcium and magnesium beside the water itself. Diuretics help to relieve the heart's workload and also decrease the build-up of fluid in the lung and other parts of the body, such as at the ankle and leg. Diuretics can be classified as loop diuretics, which inhibit the electrolyte reabsorption at loop handling, thiazide diuretics that can be predominantly found at the distal tubule, and the potassium-sparing diuretics such as antagonist aldosterone that act at the collecting duct. Thiazide diuretics such as hydrochlorothiazide and indapamide is the most common antihypertensive drugs that been prescribed either being prescribed alone or in combination with other antihypertensive agents such as ACE inhibitor, angiotensin receptor blocker, and calcium channel blocker. Hydrochlorothiazide is effective in the range of 12.5 mg up to 50 mg daily dose. However, please keep in mind, a dose above 25 mg daily is more likely to cause electrolyte and metabolic adverse events. Furosemide is the most common loop diuretic being prescribed globally. Amiloride, spironolactone, and eplerenone are the most common prescribed drugs for the potassium-sparing diuretics. The major side effects of diuretics are hypokalemia, hyponatremia, hypovolemia, and increase the production and increase the excretion of uric acid, or also known as hyperuricemia. Here is the picture of the diuretics drugs that are available in the market. Calcium channel blockers are superior to other antihypertensive agents in Asian population for the treatment of hypertension. The clinical study proved that this calcium channel blocker has high percentage in Asian countries in reducing the cardiovascular death, major cardiovascular events, stroke, congestive heart failure, and coronary revascularization. Calcium channel blocker antagonize the calcium channel at the heart and blood vessel. The main mechanism of action for this drug in the heart by slowing the heart rates through the slowing the senile arterial node conduction that responsible initiate the heartbeat with electrical impulse. This mechanism able to slow the heart rate, which allows the left ventricle to fill completely and give huge impact in lowering the heart workload. Besides that, calcium channel blocker also able to dilate both afferent and efferent arterial blood vessels. This mechanism leads to vasodilation, which decreases the peripheral resistance, hence lowering the blood pressure. This mechanism subsequently will cause reduction in the glomerular capillary pressure and can prevent from proteinuria. Thus, calcium channel blocker play a major role in prevention of kidney damage and preservation of renal function. The most common prescribed calcium channel blocker as outpatient setting were amlodipine, felodipine, and nifedipine. These three drugs share the same strength as 5 mg once daily, and the recommended maximum daily dose were 10 mg once daily. The combination of calcium channel blocker and RAS blocker such as ACE inhibitor or angiotensin receptor blocker are superior to other combinations in lowering the cardiovascular events and better safety profile. Let's discuss on the angiotensin converting enzyme inhibitors, or also known as ACE inhibitor. This class of drug inhibit the production of the angiotensin II, which is a potent vasoconstrictor and stimulator of aldosterone secretion. Besides that, ACE inhibitor also block the degradation of bradykinin and stimulate the synthesis of vasodilating substances including prostaglandin E2 and prostacyclin. Thus, this drug able to lowering the blood pressure by dilating the artery of the blood vessel. ACE inhibitor prove can lowering the cardiovascular risk, reducing the mortality and morbidity in hypertensive, congestive heart failure, post-myocardial infarction patients with reduced left ventricle ejection fraction, and those at high cardiovascular risk. These ACE inhibitors are more effective in preventing coronary artery disease in patients with hypertension. In diabetic patients, ACE inhibitors have been shown to reduce the cardiovascular mortality, prevent the onset of microalbuminuria, reduce the proteinuria, and retard the progression of diabetic and non-diabetic renal disease. The most famous side effect is persistent dry cough due to the accumulation of bradykinin. The most of the ACE inhibitor agents can be dosed once daily for hypertension, except captopril. Captopril usually given 2 to 3 times daily. Please take note, the absorption of captopril can be reduced up to 40% when given with food. Thus, it is our duty to counsel the patient to take captopril at empty stomach. Please bear in mind, patients with renal impairment can deteriorate their renal function. Thus, we need to check their serum creatinine and potassium level before the initiation of ACE inhibitor. Besides that, we also need to check back the serum creatinine level and potassium level within the 2 weeks after starting this drug. If there is hyperkalemia, which more than 5.6 millimole per liter, or persistent rise of serum creatinine level more than 30% from baseline within these 2 months, the dose of the ACE inhibitor should be reduced or we should discontinue this drug. Please keep in mind these ACE inhibitors are contradicted for pregnancy and breastfeeding women, as may increase the fetal and neonatal mortality. Angiotensin II receptor blocker, or also known as ARB, are the drugs that most often prescribed for people who experience side effects with ACE inhibitor. ARB are used to treat high blood pressure and heart failure. Rather than lowering level of angiotensin II, which as ACE inhibitor do, angiotensin II receptor blocker prevent this chemical, which is angiotensin II, from having any effect on the heart and blood vessel. Thus, the blood vessels are relaxed, which increases the supply of blood and oxygen to the heart muscle. ARB are preferable for ACE inhibitor intolerant patients that developing the dry cough. Unlike ACE inhibitor that can cause persistent dry cough, as discussed previously, ARB do not cause the dry cough. ARB are effective in preventing progression of diabetic nephropathy. Besides, it's also proved to reduce the incidence of major cardiac event in patients with heart failure, hypertensive left ventricular hypertrophy, and diastolic heart failure. However, this cardioprotective effect of ARB for prevention of myocardial infarction were recently called into question. Large meta-analyses conducted by many researchers showed that ARB, although did not increase the risk of myocardial infarction, it seemed not to have special cardioprotective effect unlike to ACE inhibitor. Despite conflicting findings from various meta-analyses, it is important to look at the original study. First, in high-risk cardiovascular patients with or without the hypertension, ARB are not inferior to ACE inhibitor for cardiovascular protection. Second, in patients with less ventricular dysfunction, ACE inhibitors have more evidence, including reducing the mortality, and ARB is used for ACE inhibitor intolerant patients. For diabetic patients with or without hypertension, and for non-diabetic nephropathy, type 1 diabetic mellitus with nephropathy, ACE inhibitor improve the cardiovascular outcomes, including the total mortality, especially in combination with thiazide diuretics. In type 2 diabetic nephropathy, both ACE inhibitor and ARB improve the renal outcome, but only ACE inhibitor has the added advantage which improving both cardiovascular and renal outcomes. Although beta blocker is not indicated as first-line treatment for the treatment of hypertension, it is useful in hypertension patients with effort angina, tachyarrhythmia, or previously myocardial infarction, where they have been shown to reduce the cardiovascular morbidity and mortality. Certain beta blockers have been shown to be beneficial in patients with heart failure. However, it is contraindicated in patients with uncontrolled asthma and any other forms of obstructive airway disease. Atenolol, betasolol, bisoprolol, and metoprolol are the four drugs that has the cardioselective at low dose, which are bind more avidly to beta-1 receptor compared to the beta-2 receptor. Thus, these four drugs are less likely to provoke the bronchospasm and cause any vasoconstriction. Thus, these four drugs are safer in patients with asthma, COPD, diabetes mellitus, and peripheral artery disease. Please keep in mind, do not abrupt cessation of beta blocker therapy, which the abrupt cessation may produce the unstable angina, myocardial infarction, or even death in patients predisposed to ischemic myocardial events. For this reason, it is always important to taper the dose gradually over 1 to 2 weeks before discontinuation. Let's back to our case study discussion. In our last discussion, we have decided that Mr. HA should receive combination therapy, which either calcium channel blocker with thiazide or calcium channel blocker with ACE inhibitor or combination of angiotensin receptor blocker with the thiazide diuretics. As our last discussion, we have known that ACE inhibitor combined with dihydropyridine calcium channel blocker such as amlodipine, felodipine, nifedipine is more preferred over the combination of ACE inhibitor and thiazide diuretic in patients with hypertension and has high cardiovascular risk. We recommended Mr. HA to receive the perindopril arginine 5 mg plus amlodipine 5 mg that available in one single pill as shown in the picture here. Most of the well-controlled hypertension patients request to stop taking their medication. Do we allow that? Yes, if this patient has following criteria, which the blood pressure must not be higher than stage 1 or mild hypertension with low cardiovascular risk. He also needs to at least has 1 year well-controlled blood pressure on the same medication at the same dose. He needs to agree to be followed up at least 3 to 6 monthly and need to be motivated to adapt the healthy living style. That's all for today. If you have any inquiries or any questions, please do not hesitate to ask me. Thank you everyone, stay safe and see you in the next semester.